Okay, good morning. Okay, can we start? Okay, the topic for today is going to be brain ischemia, imaging in acute stroke. Okay, this is one of the common requests that we get from the A&E. Okay, so what is the meaning of ischemia? What is the meaning of stroke? Any idea? Okay, ischemia is a process, okay, where you have lack of blood supply going to the brain. Okay, stroke is a clinical symptom, okay, where you have some form of neurology related to ischemia. Okay, so ischemia is lack of blood supply to the brain. Okay, that can either be due to occlusion. Okay, saluran darah itu occlude, maknanya there's no blood going to the brain lah. And stroke is a result of ischemia. Okay. Okay, so infarct. Okay, so difficult to see. Okay, so it's a sudden death of the brain cells. Okay, when there is lack of blood supply to the brain. Okay, it's a death of the brain cell due to lack of blood flow to the brain. Okay, because of blockage or rupture of an artery to the brain. Okay, so there is brain death due to lack of blood flow. Why is there lack of blood flow? Because of blockage or rupture of an artery. Okay? Okay, stroke. Okay, this is a normal diagnosis that we get. Okay, so this is a diagnosis. Okay, clinical syndrome characterized by rapidly developing clinical symptoms and or signs of focal or global. Okay, often leading to death. Okay, which is related to ischemia. I'm sorry, you can't see the. Okay, so it's most like it's always what we deal with is a vascular origin. And it's a clinical symptoms, okay, related to focal or global, okay, neurological deficit. Okay. Okay, what are the risk factors that we deal with normally? Most of the time, it's family history of CBA, TIA, transient ischemic attack, MI, myocardial infarction, hypertension, smoking, diabetes, increased cholesterol levels. Oh, sorry. Okay, previous history of CVA, atrial fibrillation. Okay, these are the common risk factors. Okay, hypertension, smoking, diabetes. I'm sure you all screen for all this. Okay, so prior to our imaging, you need to rule out hypoglycemia, dehydration, and electrolyte imbalance. And whenever there's a patient coming to the scan room, make sure the patient is stable in condition. Okay, make sure the BP, the vitals are all stable. Okay, so what is the role of imaging? Okay, the common imaging that we do is CT scan. First line of imaging is CT scan followed by MRI. Okay, but MRI depends on the clinicians. Okay, so why do we do an imaging? First of all, we need to know whether there's hemorrhage or not. Okay, because the management will depend on that. Okay, so first we need to exclude possibility of a hemorrhage. Okay, rule out other causes of stroke syndrome. Okay, determine the extent of the infarct. Okay, when there is an infarct, when the brain is dead, you need to know how much of the brain is dead. Okay, so the extent of the infarct, help assess etiology of known infarction. Okay, identify stenosis or occlusion. Okay, which part of the vessel is actually blocked. Okay, stenosis or occluded. Okay, if you all have any doubts, you all can stop me in between. Okay, so the main reason we always do the imaging is one is hemorrhage, okay, extent of the infarct, and to see which vessel is blocked. Okay. Okay, CT in acute stroke setting. Why do you all do CT rather than MR? Because one thing, it's very fast. Okay, it's cheaper compared to MR, easier to perform, widespread availability. Most places you can have a CT rather than an MR. Okay, the most treatment protocols rely on the CT-based triage. Okay, most of the time you all said if there's a bleed, then you all know you all shouldn't give aspirin or whatsoever. Okay, so it's faster, cheaper, easier to perform. Okay, okay, these are the things that are against CT. Okay, conventional CT in acute infarction is more subtle than MRI. So if you have an acute infarct, patient coming with acute infarct, okay, sometimes it is not picked up by the CT. Okay, CT takes a bit of a time compared to MR. And sometimes if the person who's reporting the films are not so experienced, they may miss that infarct. Okay. Number two, CT perfusion and CTA have made dramatic advances and could ultimately marginalize MRI diffusion. Okay, this one is not so sad. Okay, and the other one is the concern of radiation dose. Okay, MR is no radiation, CT has got radiation. So the two things are, sometimes in the early phases, CT can miss the diagnosis, and one is the radiation dose. Okay, so there are two types of strokes. One is an ischemic stroke. Okay, ischemia can be due to emboli, thrombotic, dissection, or vasculitis. These are seen in the connective tissue diseases and all. The other 20% is seen in hemorrhage. Okay, stroke. So the major causes are ischemia 80%, hemorrhage 20%. Okay. So the types of cerebral infarction, it can either be arterial or venous. Okay. So arterial, okay, can either be cortical, lacunar, hemodynamic. Okay, I'll explain these things. Venous, okay, it's either dural venous thrombosis or deep venous thrombosis. Okay, so these are the vascular territory that you encounter. I don't know whether it's of importance or not. Okay, so this is the frontal. Okay, this is the front. Okay, the brain is supplied mainly by the internal cerebral artery, ICA. Posterior circulation is by the vertebral and basilar artery. Okay, so this is the anterior circulation. This is the posterior circulation. Okay, so the anterior cerebral artery branch of ICA, internal cerebral artery, supplies this portion. Major portion is supplied by the MCA, which is also a branch of the ICA. Okay, and then this is all mainly supplied by the posterior circulation. This is your superior cerebellar artery. Okay, then you have your pica. These are all branches of your posterior circulation lah. Okay, this is a branch of vertebral. Okay, this is a branch of the basilar. Okay, so mainly what you need to know is this is ICA, this is vertebral and basilar. Okay. Okay, CT time course. Okay, within the first 24 hours, the CT can be normal. So if you do a scan during the first 24 hours, it could be normal. So normally our report will be no CT evidence of infarct. However, infarct cannot be excluded in the first 24 to 48 hours. Okay. So sometimes you're clinically suspicious of infarct and CT does not show, maybe you can request for an MRI. Okay. So the first 1 to 7 days, usually you can have mass effect. Okay, there will be some kind of edema. Okay, edema causing mass effect to the ventricles, to the sulci. Okay, those kind of things. Days to months of year, okay, then it becomes hypo. That means it becomes less dense. Okay, it's slightly on the black side. Okay, hypo means black. Okay, dense means white on the CT. Okay, 1 to 8 weeks, if you give contrast, it will start to enhance. Okay, so this is a subacute phase. Usually, you will have enhancement of the infarct. Okay, weeks to years, the brain will undergo atrophy. Okay, that will look totally black. Okay, this will appear like a bit brownish. The dense one is the acute phase. Totally black, like water, is atrophy already. Okay, early signs of ischemia. Okay, these are the important signs of ischemia. Okay, the early sign. This is where we have to pick up the infarct, not when after the brain is dead. Okay, so this is the signs of early ischemia. I mean prior to death of the cell already. Okay, so first is hypoattenuating brain tissue. That means the brain is hypo, means a bit brownish lah. It's not black, it's not white. Okay, obscuration of the lentiform nucleus. Okay, the lentiform nucleus is this part of the brain. Okay, this is your basal ganglia. Okay, this is your basal ganglia. Okay, that is a caudate nucleus. Okay, the red one is the caudate nucleus. That is a lentiform nucleus. Okay, that is your thalamus. Okay, this is your ventricle. Okay, that's your lateral ventricle. So on the side is the caudate nucleus, head of the caudate nucleus, lentiform, that is a thalamus. Okay. So if you have an early sign of infarct, sometimes you won't see the lentiform nucleus. Normally the lentiform nucleus is quite clear. You can see it bright. Okay. But if you have an early infarct, sometimes you see one side you cannot see, the other side you can see. That means there is a sign of early infarct. Okay.
This whole thing is called the basal ganglia.
This whole area is known as the basal ganglia, consists of caudate, lentiform, and thalamus. Okay. So early signs of ischemia, one is the brain becomes hypo, that means it becomes a bit brownish. Obscuration of the lentiform nucleus. The lentiform nucleus I showed you just now, you will not be able to see the margin of the lentiform nucleus. Dense MCA sign. Okay, this I'll show you later. Insular ribbon sign and loss of sulcal effacement. So normally you see the brain, you will have sulci. Okay, you will have sulci. These are the black lines going inside the brain. Okay, that's all the sulci. Okay, so you can see these things. Okay, these are all the sulci. Okay, so when you have early infarct, you will not see that the sulcus very clearly. Okay, so these are the 5 signs we have to look for: hypoattenuating, obscuration of the lentiform nucleus, MCA sign, dense, insular ribbon sign. Okay, insular is a region just in front of the Sylvian fissure. Okay, this is your Sylvian fissure. Both sides you have Sylvian fissure. The grey matter lining the Sylvian fissure is the insula. Okay. Okay. So acute infarct on CT. Just now I said one of the one is hypoattenuating brain tissue. Right? This was the number 1. When you compare the right and the left, can you see a difference?
Yes.
This region and this region, this is a bit brownish compared to the normal brain. This is the normal brain. This looks a bit dark. Agree? Okay. So this is one of the early signs of an infarct. Okay. You see it slightly dark compared to the contralateral. So whenever you have a CT, make sure you compare the side to the contralateral side. You see the right, you see the left. If you see both sides symmetrical, most likely it's going to be normal. Not always, but it's most likely going to be normal. Okay? So here you see the posterior looks about the same. But here, this one looks darker compared to that. Right? So that is hypoattenuating brain tissue. Okay? Because this is an acute infarct, you can have mass effect. Look at the sulci, this is the sulci. Agreed? This black line going in, that's the sulci. Can you see it on this side? Okay, that is because of the mass effect. It face the sulci. You don't see the sulci as clearly on the left. Okay, so sometimes you may not see this thing as dark as what we are seeing here. Sometimes it's very vague. But if you don't see the sulci, then you should suspect there is some kind of infarct. Okay. Okay, that is obscuration of the lentiform nucleus. Just now I said this is the ventricle, that is a caudate, that's the lentiform nucleus, that is the thalamus. Normally the lentiform nucleus will be bright. Okay, but now you don't see the bright thing already. See, the thalamus is bright, but this one you don't see. Grey matter will appear bright. Okay, white matter will appear dark on CT. Okay, normal grey matter will appear bright. White matter, this internal capsule or white matter will appear slightly on the darker side. Okay, so this is the insular ribbon side. Okay, I told you it lines the Sylvian fissure. That is the Sylvian fissure. Sylvian fissure. Here you have white. Here you have black. You can see. Next, the Sylvian fissure. This is the Sylvian fissure. Okay. This side you got Sylvian fissure, but this side you got black. Here you don't have the black. Can make up this.
That's the infarct.
Yeah, that is the infarct.
How does it look like a ribbon?
Oh, imprint, the word, I don't know why.
Is it a ribbon or a ribbon is somebody's name?
No, it's a ribbon sign.
Ribbon.
Yeah, okay, like a thread thing, so it looks like so the name was given insular ribbon sign. Insula is the region in front of the Sylvian fissure. Okay, so the moment you have an insular ribbon sign, it appears dark. Okay, so the moment you don't see that, you don't see this the normal insula. Okay, when you see this is an early sign of an infarct. Okay. This is the dense MCA sign. Okay, this one most of you all know. Okay. Normally you don't see the MCA as dense as this. This is where the MCA travels. Okay. ICA comes, divides, goes into the Sylvian fissure. This is the MCA, left MCA. This is your right MCA. Which one nampak lebih terang? The left. So this is the dense MCA sign. Why does it appear so dense? It's because there is a thrombus. Okay, the thrombus in the CT will appear dense. Okay, so that is a dense MCA sign. Okay, so these are the common signs that you're going to see in an acute infarct. One is hypoattenuating. Okay, other one is obscuration. The lentiform nucleus tak begitu nampak. Insular ribbon sign, that's just beside the Sylvian fissure. The Sylvian fissure. Here you don't have the black line. There you can see the black. Okay, see that's the lentiform nucleus. Here you can see the lentiform nucleus. So that is your insular ribbon sign and your MCA. That's MCA sign. Okay, so this is more dense. So your infarct is going to be on this side.
If there is if there is severe atherosclerosis there,
that is quite
similar like this.
Yeah. Okay, but usually atherosclerotic should be generalized rather than
White.
focal. Okay, so if you see symmetrical, then it can most likely it is not. Okay, sometimes high hematocrit levels, okay, also can cause this thing to be dense. So that's why you have to exclude everything. And if you see, like I said, if you see symmetrical, then very unlikely. Okay, whenever you see imaging, always compare to the contra. You see one side more dense to the other, and your symptoms relate. Let's say you clinically you all assess the patient, you all say the symptom is on the right side. We see the left dense MCA side, then for us it's most likely an infarct. Okay? Okay. Okay, hemorrhage, bleed. Okay, hemorrhage means bleed. Okay, so far infarcts we have seen, normally infarcts are what color? It's all black, hypo. Okay, it's either black or brown. Okay, whereas the hemorrhage look white. Okay, all hemorrhages will appear white. Okay. And what is the thing surrounding the white thing? Okay, that is the edema. Okay, so the black will appear edema. So anything fluidy will appear black. Ventricles are fluid, CSF filled, okay, fluid filled, black. Edema, black. Okay, anything dense, okay, apa-apa yang keras, that will appear white. Okay, skull wall, okay, bone appear white. So these are all white. Okay, bleeds are white. Okay, if you do an MRI to confirm a bleed, okay, these are few sequences. This is a gradient echo sequence. Okay, this is a one sequence that we do to confirm whether there is a bleed or not. Sometimes we are not too sure. Okay. So when we do a gradient echo sequence, if it's black, okay, if it turns out black, then it is a bleed. Okay, this is known as a blooming artifact. Okay, if you see the gradient echo sequence, okay, and you see this thing black, and you saw the CT also showing that, then it's most likely a bleed. Okay, this is a special sequence done for bleed. Okay, chronic infarct. Just now I showed you all acute. Hypoattenuating, dense MCA sign, and Lentiform nucleus, all those are acute infarcts. Okay, this is chronic infarct. Okay, look at it, it's already atrophic. Okay, black, fluid already. Now, when you see a chronic infarct, normally the density of that becomes equal to the fluid, the ventricles. Right? See, this ventricle is CSF filled. This is a chronic infarct. It is also like fluid already. Okay, so the density of this is seen, the color of this same as this, so it's already a chronic infarct. And normally chronic infarct, when you compare the sulfide on this side, we compare on this side, which one appears more prominent? The right side or the left side looks more prominent? Right side. Okay, the right side sulfide appears more prominent compared to the left. Agree? Okay, that is become a volume loss. Okay, because of atrophy, the brain undergoes atrophy. There's volume loss, the brain becomes shrunken, so the sulci become big. More area of the brain is filled with water compared to the contralateral side. Okay, whereas in acute infarct, the sulci will be not clearly seen. Just now when you saw the earlier one, okay, when you see the acute infarct, okay, you don't see the sulci so clearly. Okay, whereas in a chronic infarct, the sulci will appear more prominent. Okay, see the sulci will appear more prominent. And usually that ventricle adjacent to that chronic infarct, it is a ventricle, correct? Lateral ventricle, which appears more prominent? Right appears more prominent. So adjacent to the chronic infarct, there will be what we call as ex vaccio dilatation of the lateral ventricle. Okay, that dilatation, okay, the one is what we record as, okay, so there is chronic infarct with adjacent ex vaccio dilatation of the adjacent lateral ventricle. So normally when you have chronic infarct, one thing, the sulci will be prominent, then the ventricle compared to the left side will also be prominent. Okay. Okay. So what is cortical laminar necrosis? Okay, the cerebral cortex, the cerebrum, okay, the brain, right? Okay, I've got 6 layers. 1, 2, 3, 4, 5, 6. Okay, you don't need to know all that. Okay, in cortical laminar necrosis, the 3rd, 4th, 5th layers are involved. Okay, the brain consists of 6 layers. Okay, molecular, outer, all this, I also don't know. Okay, I only saw yesterday. Okay, so they have got 6 layers, out of which 3rd, 4th, and 5th play a role in cortical laminar necrosis. Okay, so what is cortical laminar necrosis? Okay, it is characterized by the cortex cell death, mainly in the 3rd layer. Okay, I said 3rd, 4th, 5th, but mainly involving the 3rd layer. In situations of reduced energy supply to the brain. Okay, So if there is decreased energy supply to the brain, the cortex involving the third, fourth layer, mainly the third layer, start to die. Okay. So how does the brain get the energy? One is via oxygen. Okay. So there is no oxygen, lack of blood oxygen, and also through glucose. Okay. So if there is glucose depletion, anoxia or ischemia, there is cortex of the brain becomes dead. Okay. So how does a cortical laminar necrosis appear on a CT? So when we do a CT, normally you will have this line, putte, along the gyri. This is the gyri. Okay, that is the sulci. The sulci is lined by gyri. That's a gyriform. So since the dense thing follow the gyriform, it is known as gyriform hyperdensity. So if you have some density, putte to following the gyri of the brain, that is cortical laminar necrosis. Okay. If you give contrast, it will enhance. It's mainly seen in your subacute and your chronic phases. If you see this thing, it will appear dense. Okay, you don't have to give contrast, it will already appear there. Okay, so that is cortical laminar necrosis, where you have cortical necrosis secondary to either oxygen depletion or glucose depletion. MCA infarct. Which side is infarcted? Right side is infarcted. Okay, this one looks darker compared to this. Agreed? Okay, so this is an MCA territory infarct. Okay, look, when you do a CTA, you don't see the MCA. That is the MCA. Okay, on the left side looks normal. Here cut off. Okay, the contrast doesn't go there already. Stop. Okay, most likely there's a thrombus there. So this side the contrast goes to the end. So that is a dense MCA sign. Or what is CTA? Okay, when we do the CTA, you don't have the contrast going because there is a block. See, this one is blocked. This one, the whole length of the MCA can be seen. Okay. Okay. What is lacunar infarcts? Sometimes we record multiple lacunar infarcts or varying ages. Okay. So this is what lacunar infarcts are. Okay. Lacunar infarcts are usually small infarcts, less than 20 mm. Okay. They mainly result of occlusion of one of the small penetrating end arteries at the base of the brain. Okay, so it's mainly involving the end arteries. Okay, bukan yang MCA macam tadi semua. Okay, not involving the MCA, AC and all. It's one of the end arteries, and it's usually less than 20 mm in size. Okay, so like this. Okay? We have this kind of infarct, right? The small infarcts as now. Okay, earlier one was all huge one, right? Okay, so you have small infarcts, okay, usually involving the end arteries, okay, less than 20 mm, these are known as lacunar infarcts. A lot of patients after 50 you scan, most of us will have infarcts, some form of lacunar infarcts. Okay, what is watershed infarcts? Okay. Watershed infarcts occur in border zones. Okay, that means they occur in border zones, meaning that means there is a border, that means between two vascular supply, you have infarcts. Okay. Border zone between major cerebral arterial territories as a result of hypoperfusion. Okay, so it can be two types. One, you have cortical border zone infarcts, okay, and internal border zone infarcts. Cortical is also known as external border zone. Okay, since there is an internal, it has to be an external. Okay, cortical border zone infarcts like this. Okay, this is the cortex, right? This area is supplied by the MCA. The red is the MCA territory. This is the anterior cerebral artery. Okay, this is the branch of the ICA. This is the MCA territory. Okay, so this is supplied by both, correct? By the ACA and the MCA. Okay, so this is the border zone infarct. Okay, because it has got supply from both the vessels, ACA and MCA. So that is known as the cortical border zone infarct between the ACA and MCA vessels. This one, is this a cortical border zone infarct or internal infarct? This is also a cortical border zone infarct. Okay, because this is a supply from posterior cerebral artery. Okay, this is anterior cerebral artery, this is the posterior cerebral artery and the MCA territory. So because it receives supply from dual, this is a border, right? Okay, so that is also a cortical border zone infarct. Okay, cortex means outside. Okay, if it is internal border zone, this is lying here. Okay, so this is mainly from the penetrating branches. Okay, mainly the deep and the cortical vessels of the MCA. Okay, so the deep and the cortical branch of the MCA border zone will cause infarcts inside. Okay, this is known as the internal border zone. Okay, so you have cortical and internal. Okay, cortical is usually from ACA and MCA, or posterior cerebral and anterior, middle cerebral. So in both areas, MCA is involved. It's in the front, anterior, posterior, cortical. Okay. Want to ask any questions? Okay, yeah. Okay. So this one, watershed infarct. So is this an internal or an external watershed infarct? Okay. This is an internal watershed infarct. Okay. This is not outside. It's not a periphery. This is an internal. What you see. Okay. So normally internal watershed infarcts occur in the centrum semi-ovale. Okay. And normally it occurs in the centrum semi-ovale, and the corona radiata. Okay, where is the corona radiata? Okay, centrum semi-ovale is this part you see here. Okay, this part above the ventricles. That means at the level of the ventricle, it is still known as corona radiata. Above the level of the ventricle, that is the centrum semi-ovale. So let's say you see the image and you see this one, you don't see the ventricle, that is the centrum semi-ovale. But when you come to this level, you can see the ventricle, that's the corona radiata. So any infarcts occurring at the level of the corona radiata or the centrum semi-ovale, like this, okay, it's above the ventricle, coming inside of the brain, that is a watershed infarct. Okay?
Ask about the diagram, the picture we get sometime.
This one is ICA block. Okay, that is a CCA, ECA.
What study is that?
This is the cavity Doppler. Okay. This is the watershed infarct. Just like this is the watershed infarct, right? How many types of watershed infarcts are there? Huh? How many types of watershed infarcts are there? There are two types, right? Cortical, internal. Okay, so cortical, internal. Okay. So this one you all said is an internal watershed infarct. Okay. This one, yeah. This is a cortical. Very good.
This is MRI.
This is an MRI. Okay. So this is a cortical infarct because it's lying in the periphery. And it is an anterior. So this is MCA and ACA. Okay. So this is a cortical watershed infarct involving the MCA and ACA. What about this? Is this a cortical or an internal? This is an internal. Okay. So this is at the internal watershed area. Okay. This is at the level of above the ventricle, below the ventricle. Do you see the ventricle here? So this is above the ventricle. So this is the central semi-ovale. Okay? Okay. This one. Is this a cortical or an internal? Okay. Which is the vascular supply? Okay, very good. Okay, so this is the posterior part of the brain. Okay. So this is the watershed area involving the MCA and posterior cerebral artery. Put it. After this, a quiz, you know. Okay. Cerebral venous infarction. So infarct can be due to earlier, just now we said as arterial. So long what I showed you just now, all is arterial, right? All the internal cerebral artery, anterior cerebral artery, middle cerebral artery, posterior cerebral. So all those were arterial. Now it is because of venous. Okay. Vein also can be blocked. Okay. Usually sequelae of cerebral venous thrombosis. Okay. Complicating both dural sinus and deep cortical sinuses. Okay, other causes include, okay, it can be due to trauma, suffered and during surgery, some accidental ligation. Okay, so normally when you have a venous infarct, usually you have hemorrhagic transformation. Okay, I'll tell you what hemorrhagic transformation is later. And usually they appear heterogeneous. The bleed usually appear heterogeneous compared to the normal bleed that we have in hyperdensity bleed and all. Okay, so it is normally due to the vein being thrombosed. Okay. Usually involving the dural venous sinus and the deep cerebral veins. Okay. So, and then the other causes can be trauma. Okay. Normally you have hemorrhagic transformation and usually appears heterogeneous. Okay. This one, unfortunately, there is no. Okay. Actually, the sinus we have okay, the deep and the sagittal, all the major sinuses lah. Okay, the side usually you have your transverse sinus. Okay, you have the transverse sinus. On the superior aspect, you have a superior sagittal sinus. Okay, so I don't have an image of the sinuses. Okay, so here, just like your dense MCA sign, okay, the dense one was the MCA, right? Okay, here this appears dense. This is your transverse sinus. This is where your transverse sinus goes. Okay, and look at this area. Is it black? Okay, so that is already an infarct area. That is a sagittal, your venous sinus thrombosis. Okay.
Maybe associations apart from trauma.
Which one?
If somebody has malignancy, what causes the thrombosis?
Can be due to thrombus, can be due to infected. Okay, so sometimes when you have cases of thrombosis, you have to look for any form of sometimes chronic infection, malignancy. Okay, so they can involve the sinuses. Okay, so this is your transverse sinus. Okay, this is also your transverse sinus. Normally, this is MRI. Normally, you should see flow white. You don't see anything within the transverse sinus. It should be black like this. But here you can see there is something around. Okay, so that is a venous sinus thrombosis. Okay, MRI transverse sinus thrombosis. This is where your transverse sinus goes. You have one on the left, you have one on the right. So results in a venous sinus thrombosis. Okay, but this one, if you ask me, this one also looks like an MCA infarct, right? That's an MCA. MCA supplies this area. So MCA also can appear like this. So when you do a CTD or something, you'll find out that the venous sinus is blocked. When you do a CTD is a study of the venous sinuses. So you won't see contrast going into the venous sinus, the transverse. Okay. What is hemorrhagic transformation of an infarct? Okay, it's a complication of cerebral ischemia, infarction, and can significantly worsen the prognosis. Okay, so normally an infarct undergoes hemorrhagic transformation. Okay, so when does it normally undergo transformation? Infarct, I said, is black. Okay, so let's say this is black, but suddenly in the black area you got blood. Okay, so this infarct has undergone hemorrhagic transformation. Okay, if it's untreated patient, that means the patient is not being treated for anything. Okay, within a few days, okay, the patient can undergo hemorrhagic transformation. The treated patient, let's say you are treating the patient for some infarct, the patient can usually will undergo the hemorrhagic transfer earlier within the first 24 hours. Okay, so for an untreated patient, it usually occurs within a few days. In a treated patient, it usually occurs earlier within the first 24 hours. Okay, so it's an infarct undergoing bleed. So like this patient, it's infarct. Okay, after a few days, now you are seeing there is a bleed. So that is a hemorrhagic transformation. It's one of the complications of an infarct. Okay. Okay, so the imaging is coming to the end of it. Okay, this is an MRI imaging. Okay, MRI very rarely we do. Okay, but sometimes the neuro team and all they ask us. I don't think we all ask us that frequently. Okay, so the normal sequences that we do on MRI is your T1 image, T2 image, flare, DWI, MRA. Okay, these are all sequences that we commonly do in a brain lab. Okay, this is a T1. Okay, this is a T2. This is a flare. This is a DWI. Okay, this is a T1 sequence. When you see a T1 sequence, infarct will appear light. You won't see very clearly. Okay. T2 and flare is about the same, but T2, this is fluid, right? This is a ventricle, I think. Okay, what is within the ventricle? Fluid. So on a T2 image, the fluid will appear bright. On a T1 image, the fluid will be black. Okay, when you see an MRI scan, if you have a scan, you will see the ventricles, the sulci and all, the fluid will appear black. Okay. If the fluid is bright, then there is a T2 sequence. Okay, here the sequence is actually the same as the T2. It's a flare sequence, but flare sequence, what it does is it suppresses the fluid. Okay, whatever that is white, now it becomes black. Okay, but otherwise everything else stands the same. The only thing that happens in a flare sequence compared to the T2 sequence, it suppresses the fluid. Okay, apa yang putih akan nampak hitam, flat. Okay, this is a DWI sequence. Okay, DWI is diffusion weighted images. Okay, diffusion weighted image is mainly to see the fluid. Okay, so if something appears very bright on your DWI, okay, that means it contains some kind of a fluid. Okay, that means some edema. Let's say in acute infarct you have edema, right? Okay, normally acute infarct you have edema, cytotoxic edema. Okay, that means fluid goes into the cell. Okay, so when fluid goes into the cell, that cell becomes highly concentrated fluid, so it appears as bright on DWI. Okay, because of the fluid, just now I told you the fluid goes into the, what is that? Into the cell. That's why it appears white on the T2. T2 will show fluid as bright. CSF is bright, so because of the edema, this so-called infarct will appear bright. DWI will just tell you whether it's an acute infarct or a delayed infarct, chronic infarct. So if it is bright on DWI, it's an acute infarct. Let's say we do the scan, we know there is an infarct, but we don't know the aging of the infarct. We know this is low, this is high, bright, low, we know it's an infarct. Okay? But if you ask me whether it's an acute infarct or an old infarct, I may not tell you. Okay? So we normally do a DWI. If it is bright on your DWI, it's an acute infarct. If it's low, it can be an infarct, but most likely an old infarct. Okay? If this one is not, this is not one of my specialty, this is more of the interventions people. Okay, my one was the earlier one, the diagnostic part. Okay? So thrombolysis is one of the treatment nowadays they do. Okay? Thrombolysis is mainly for not when you have chronic infarct. Okay? So that is why you have to identify the infarct when you have all the dense MCA sign and all those things. When it's not the tissue cannot be dead. Once the tissue is dead, there is no use of doing thrombolysis. Okay? It can be because when you have ischemia, okay, the blood, I mean not going to the brain, the part of the brain can die, but some part are not dead yet. Okay? So you want to salvage that non-dead part. The dead part you can't do anything. If you do the CT perfusion, if the whole brain is dead, then there's no discussion about thrombolysis already. Okay? But if you do the CT perfusion, you find that some parts of the brain are not dead. Some parts are still, if you give oxygen or you give something, it will function, then you can do a thrombolytic therapy. Okay? That means the patient, the brain is not dead lah, ischemia saja, dia bukan mati dah. Okay? Kalau sudah mati, there's no use of thrombolysis. So when can you do thrombolysis? Normally within the first 4 hours. Some people say 6. Okay, this article they said within the first 4 to 5 hours you do a thrombolysis. I mean the patient come to this, but this is very rarely we get a chance to do this. Okay, because by the time the patient come to the A&E, patient already symptom late night. Come only realize in the morning. Okay, by the time from A&E come to CT, 1 hour. Okay, CT suggests MRI, more than 4-5 hours. Because when the patient sleep, we don't take the onset as that. When the patient wake up, patient tell you got weakness, right? Patient sleep, wake up, got weakness, he tells you. But you don't know when the stroke started, maybe during sleep. Okay, so we cannot consider the time that he says as the time that the symptom started. The symptom we have already, when he was sleeping, he already had it. Okay, so thrombolysis is a forefront of modern management of acute stroke, with good evidence of its efficacy if it is done within the 4 to 5 hours of symptom onset. Okay, normal complication of thrombolysis is hemorrhage. Is the major complication associated with thrombolysis in acute ischemic stroke, and key factors increasing the bleed could be increasing age. Okay, so if the patient has got elderly patient, high blood pressure, diabetes, and if the stroke is very bad, then these are patients who are more prone to bleed on thrombolysis. Okay? I think that's it. Okay? Any questions?